My name is Davenport, and I'm an occupational therapist. First, I would like to thank you all for joining me today and taking time out of your schedules to watch my presentation. Before I get into my presentation, I would like to share a little bit about myself. I'm from Erie, Pennsylvania, which is where I currently live. I also attended school in Erie at Gannett University, where I studied occupational therapy. Last May in 2022, I graduated with my master's in occupational therapy, and this past June, I was lucky enough to be hired through ACMC and start my first job and start my career as an occupational therapist. I work right next door to Premier Fitness at ACMC Rehabilitative Services and primarily work with children, which is what led me to choose my topic today, pediatric occupational therapy. There may be some of you who have heard of pediatric occupational therapy or are familiar with it, but those of you who are not, pediatric occupational therapists evaluate a child's current skills related to play, school performance, and daily activities and compare them with what is developmentally appropriate for that age group. OTs help children perform daily activities they may find challenging by addressing sensory, social, behavioral, motor, and environmental issues. As an occupational therapist, our goal is to improve the participation of the child within their occupations and improve their quality of life, which I will go into occupations later in the presentation. Pediatric occupational therapists can work in a variety of different settings. Some include early intervention. In this setting, the therapist would work with younger children, ages birth to 3 years of age, and typically this is done within their natural environment, that being their home, but also can be in a clinic setting, daycare, or telehealth. Another setting is school-based. OTs working in a school setting are going to work with a child if it's affecting their education. So some things they may work on are graphic communication, such as writing, typing, and drawing, the use of classroom tools, such as using scissors and glue, personal care, being able to take off their coat and put back on, as well as manage the fasteners, social skills, and self-regulation skills. Another setting is clinic-based, such as where I work, and outpatient. Within this setting, we do see a wide variety of diagnosis and treat many different types of skills. In this setting, we typically treat children ages 3 to 18 years of age, and some clinics may specialize in certain areas such as neuro or autism or even feeding. And within these clinics, it may only be that OT services are available, but also there may be additional disciplines such as physical therapy and or speech therapy. There are a range of diagnoses that a pediatric occupational therapist could work with, but some more common ones include autism, which is a neurological and developmental disorder that can affect how a person is able to interact with others, communication, learning, and behaviors. Attention deficit hyperactivity disorder is another common diagnosis, which is better known as ADHD, and this is a neurodevelopmental disorder that can cause difficulty with paying attention, controlling impulsive behaviors, and overly the child is just increasingly active. Developmental delay, which is a more general term, this refers to a child that has not gained the developmental skills expected of him or her when compared to those of the same age, and delays may occur in areas of motor function, cognition, speech and language, play, and social skills. Fine motor delay, this is when an individual struggles or is unable to hold, manipulate, and use objects involving small muscles in their bodies, such as within their hands, fingers, and the wrist. And lastly, sensory processing disorder, or SPD, which is a condition that affects how the brain is able to properly synthesize the sensory information within their environment. So this could be things that a person is seeing, hearing, touching, tasting, or smelling. As I mentioned previously, occupational therapists help to engage individuals in their occupation. Within this context, an occupation is not a 9-to-5 job, but rather a meaningful activity that has purpose and value to that person. Occupations are ordinary things a person completes every day that makes up their day-to-day routine. Some occupations that a child may engage in are ADLs, or activities of daily living, and these are basic self-care tasks, such as dressing, feeding, grooming and hygiene, toileting, and bathing. Another area of occupation are IADLs, which are instrumental activities of daily living, and these are tasks that the individual will complete to take care of himself or around the home. So for a child, this may look like taking care of others or siblings, pets, having to do laundry, meal prep, cleaning their room. It can differ from child to child. Another area is rest and sleep, social participation, education, so their role as a student, and also play and leisure. Specific skills that a pediatric occupational therapist might address and work on with that child to promote participation within those occupations include, but are not limited to, fine motor skills. So again, the small movements, whether that's the hands and fingers, toes, wrists, lips, or tongue. But specific to the hands and fingers, this could include things such as holding a pencil, using scissors, managing fasteners and or toys, or handwriting. Gross motor skills, which are larger movements and coordination of the arms, legs, and body parts. And this is to help control the body. So examples would be balancing or using both sides of the body to coordinate to complete different tasks. There's also visual motor skills, so the ability to visually look at an image and translate that into a motor action, such as building blocks, catching a ball, tracing, or writing. Sensory processing skills, social skills, whether that's verbally or non-verbally, being able to communicate with an individual. Emotional regulation, attention, and safety awareness are also skills that can be worked on. So when thinking about how a child might receive services and if deemed appropriate, what that process looked like, I wanted to include the OT process, which includes referral, evaluation, intervention, and outcome measure. So the referral is the first part, and that's the initial contact between the patient and the therapist. There's a variety of sources or people that can refer a child to an occupational therapist. However, it's most commonly by the physician, as this is required by most states and or insurance providers. Next is the evaluation, and this helps the therapist to get a better and bigger picture of what's going on with that child. It's within the evaluation, the therapist will assess them to get a baseline performance, determine strengths and deficits, and also help to develop goals. In the evaluation, the therapist will assess the child's occupational profile, so looking at those needed and wanted occupations that they need to do in their everyday life, and then analyzing their occupational performance, so what's their ability to complete those occupations. It's also important that during the evaluation, the therapists look over and ask if there's any past or relevant medical history that may be affecting their current functional ability, and interviewing the parent as they're with this child every day so they know best. Also in the evaluation, a therapist may use standardized assessments, which help provide a score of baseline performance comparing with age-appropriate developmental norms. This also helps the therapist in the intervention process to be able to track and monitor that child's progress throughout the intervention. After evaluation is intervention, and this is implementing plan of care to meet desired outcomes, which are identified in the goals. So this includes planning the treatment, actually implementing it, and then reevaluating to check and see if the child has made any progress, or and then maybe if things need to be adapted or changed to help them meet those goals. The intervention should be evidence-based and, again, focus on those child's engagement in their occupations. And lastly, outcome measures. So this is the focus on the end result, and simply it helps to measure the result of intervention and identify how well the client was able to meet goals, or maybe they were unable to meet their goals. And there may be a continuation of services or discontinuation of services, and this is patient-based, just depending on their diagnosis, their skill deficits, and more complex diagnoses may require continued services over their lifespan to help them meet those goals and develop the certain skills they need to participate in their daily life.
So how do they determine, like, at what age do they determine that a child needs occupational therapy? I mean, is it 10? I mean, how do you determine, like, you know,
so
is it based on the parents' decision or when you go to the doctor? Or?
I think it's a little bit both of both the parents and then the physician's decision, because again, the parent being with their child every day, and especially if they've had children prior to that, knowing what those child did at that specific age and were meeting their developmental milestones, and maybe this current child is not meeting those, so then that brings up some concerns for them, and then taking them to the physician, sharing those concerns, and then the physician saying, oh, well, I think that maybe they would benefit from OT, and then sending them over to us to then again evaluate them to see if they actually would benefit from services.
So how long actually has occupational therapy for children been, like, I mean, when I was a kid, I mean, there was nothing like that. You know, you just
good
sort
question.
of, oh, you're just not going to learn as quick as the other person.
To be honest, I'm not entirely sure. I mean, I did schooling for 5 years, and there was like heavy focus later as we were approaching grad on pediatric care. But I do know some of my professors, they themselves had been in the field for 30-something years, and specifically my pediatric professor, she had been a pediatric occupational therapy for 25, 30 years. So I would say maybe somewhere around there.
Yeah, I mean, even with my children who are going to be 40, I don't remember, like, when they were in school, you know, any of the kids, like, going to occupational therapy. And now all of a sudden it's very prevalent.
Yes.
Like with my grandchildren, like I said, I have 3 grandchildren who go to occupational therapy.
Yes. I also think that it might just be that there's more awareness too around occupational therapy as a profession. I know I still have a lot of people, when I tell them I'm an occupational therapist, they think I work with people to get them back to being able to work with their jobs and their
careers.
careers.
I think where it originated, right? I mean, that's really mostly where that was, is like occupational therapy was in companies where, you know, like employees.
Yeah. And then also with just different state like laws that were put in specific to like the IDEA, putting more services in place for children. So maybe starting there in the classroom, they were seeing issues, and then eventually just started growing to different settings.
But also, isn't it true that for just certain kids, you know, like my daughter read before she was in kindergarten. My son never read until he was almost in first grade.
Yes.
Just, you know, some kids just develop.
Yep. I was just going to say, as human beings, we are unique individuals, so there's not two people that are going to follow the same exact line, especially with meeting developmental milestones, and it's not a bad thing if a child is meeting developmental milestones a little bit earlier, a couple months late. I think where it's really concerning if it's like at least over a time period of 5 or 6 months where they're not able to then work on the other skills that come after developing those previous skills.
So if it's a behavior, it's sort of a behavior issue. You know, like you said, ADHD, that kind of stuff. What is the process to treat them? I mean, how do they treat them? How do they manage their anger, their attention?
So some things I do in therapy is I actually use a visual schedule that just helps, I think, prepare them for what's going on throughout our session, and then also with transitions, because if they're having fun doing whatever task or activity I have them engaged in, and all of a sudden I said, okay, we're done and we're moving on, that for some of the kiddos I am treating is really tough for them. So I actually have them involved with their visual schedule where when they come in, they see what's going on for the day, and then as we go through each task, they go over and they get to put it in from the to-do pile in the done pile. It's improved their behavior and their ability to just regulate their emotions a lot. I also do different games working on impulse control, like Simon Says, red light, green light, which they think we're just playing a game, but it's also for them to have to stop, think about like what's being told to them, what the next action should be. And then also another tool I use is the zones of regulation, which breaks it down into 4 colored zones. Red, blue, green, and yellow, and green is the zone you want to be in, which means you're calm and focused and ready to learn. And so we do different activities with that for them to be able to identify different emotions go in these different zones, and then developing tools that I have over at where I work and then at home that they can use to help get them back to that green zone so that they're ready, they're listening, they're following what they need to do, and overall they're just more regulated.
So as a grandparent, like if they're staying in my house and they get out of that zone, how would I as a grandparent get him back in that zone? Like what tool could I use?
Well, so it's dependent upon the child, because what works for one might not work for others. Some might need more calming activities, like maybe deep breathing or yoga, or some older kids journaling. even just doing I don't know if I understand this, but breathing exercises to make them stop and think about how they're feeling and just calm them down. But also maybe some more alerting and movement activities, like if they're kind of crazy everywhere, letting them get that movement out, and they might prefer vestibular, so going on the swing or rolling, or they might prefer more proprioception, so like the pressure through their joints, so maybe jumping on a trampoline, doing jumping jacks. So I guess it's just more specific to the child, and it is trial and error finding out what works specifically for that child.
Have you seen, I mean, do you think there will be a rise of children more social during COVID? Because I know this was my grandchildren, the ones that were young during it, didn't want to be around people, wouldn't interact, or they'd turn their heads if anybody talked to them, they'd say, I don't want to be with these people. I mean, we're talking 3 and 4-year-olds.
Yeah, I do think so. I mean, even a child going to daycare, they're around peers that are the same age, and they're able to interact and start learning things like how, it's appropriate to play, and sharing and taking turns, and, not just grabbing a toy out of someone's hand, asking first. So at home, unless they have siblings, they're not getting that. And even sometimes siblings, it's tough. They don't always get along. So I do think that I'll see that in regards to like socializing with others.
Sure.
I've only had one kiddo that I'm seeing right now specific to that, but I do think we'll probably see more just because they're not getting those typical experiences that maybe they will.
Yeah, I can see a lot of kids utilizing occupational therapy just to get them through that social, even the learning that they've missed out on.
Yeah. If the parents having to do it on their own and figure out ways to incorporate that, which maybe they don't know exactly like what to do because they're not typically
is it covered by insurance, like through their insurance, or does it, if it's something
it's I think dependent upon different insurance providers. Some will allow a select amount of visits. I know I've noticed a couple, they by what the codes we input, different areas like therapeutic activity and therapeutic intervention, or if you're doing range of motion and strengthening, there's different units. So some insurance providers authorize a certain amount of units versus rather just an X amount of treatment sessions. I do know, at least just from my little bit of experience, that it seems that some insurances do allow more, and even if services need to continue, it's not as hard to get that approved and keep going, but others are, it's like once you hit your cap for the year, it's it.